All right, so today we'll be talking about pulmonary embolism, the endovascular and hybrid approach, the PERT team that we have. I have no disclosure. A quick outline about the lecture today. We'll talk about the incidence of PE, the signs and symptoms, PE classifications, risk stratification of PEs, therapeutic options, including catheter-based therapies, and the PERT team that we have at Orange Park and Memorial. The paradigm shift in VTE management, DVTs, and the DOAC dosing we can go over quickly. So venous thromboembolic disease is highly prevalent. It's the major cause of hospital morbidity and mortality. There is over more than 900,000 patients diagnosed with VTE annually in the US. So technically, 1 out of 5 of these patients will be admitted within 30 days. VTE kills more than 200,000 of US patients annually. And it costs, the cost is around 10 billion for the US economy. So PE is a highly emergent condition, as we know. It's #1 cause of preventable death in the hospital. It's the 3rd leading cause of cardiovascular death. And the short-term mortality of massive and submassive PE ranges still today from 12 to 50%. And it's associated with long-term complication. Residual pulmonary vascular occlusion is common, is up to 50%. And way less than that, we get chronic thromboembolic pulmonary hypertension, CTEPH, class 4. DVT is also a high acuity condition. It's the #1 cause of PE, is actually embolization of DVT. 50% of DVT patients, they develop post-thrombotic syndrome, PTS, which is a chronic and lifestyle limiting disease that includes swelling, pressure, chronic pain, and even ulcers. 90% of these patients, they're unable to work at 10 years after the diagnosis. So for the APPs, and I was hoping that the newbies would be around, the signs and symptoms include the symptoms include dyspnea, chest pain, palpitations, dizziness, syncope, or flank pain from pulmonary infarct. So you can see it's a broad spectrum of symptomatology that is sometimes non-specific. We see all these symptoms in the ER. Not a lot of them are PEs, so it's important to try to identify the PE patients early. The signs on physical exam: tachycardia, tachypnea, RV strain, JVDs, loud S2, pulsatile liver, parasternal heave. If you can feel one, just let me know. EKG findings, you see sinus tach, anterior precordial T-wave inversion, and the famous S1 Q3 T3 on EKG. So there's an S wave in lead 1, a Q wave in lead 3, and a T wave inversion in lead 3 as well. With some precordial ST elevation, sometimes you can see it. On echo, we see RV, right heart dilation, RV dilation, RA. There's septal shift. There's usually signs of pressure overload. In systole, you see the septum moving towards the left ventricle. McConnell sign, where there's an RV free wall akinesis that spares a hyperdynamic apex typically. So PE the classification is typically classified into massive, submassive, and low risk. And the management between massive and low risk is pretty clear cut. But let's talk about the classification itself. For massive PE, by definition, sustained hypotension, blood pressure less than 90 for 15 minutes or requiring inotropic support. Pulseless, that's by definition is massive. Sustained heart rate less than 40 beats per minute with signs of shock. Submassive PE, you'll need blood pressure still more than 90 with RV dysfunction and myocardial necrosis, defined by RV dilation. In the apical fourth chamber, you see the right ventricle enlarged. Elevated BNP, some biomarkers, BNP more than 90, NT-proBNP more than 500, some EKG changes, complete or incomplete right bundle. That's pretty specific when it happens. Elevated troponins more than 0.4. The low risk PE, the absence of any of these markers. So for massive PE, the data is clear still. Lytic therapy is still a 2C indication for unstable patient with systemic, with massive PE. And this data comes back from the original studies where they compared these patients with massive PE. They gave thrombolytic therapy to 21,000. This is a retrospective analysis. And the mortality is markedly reduced in the thrombolytic therapy, but it is still at 15%. So it's still high mortality, but markedly reduced compared to conventional therapy, which is anticoagulation alone. For submassive PE, tried systemic TPA, the PITO trial, they look at this subgroup of patients with submassive PE. There were improved outcomes. There were reduction in mortality as the primary outcome, and that was statistically significant. There is less hemodynamic compromise. However, on the other hand, there was increased bleeding. And the group that got fibrinolytic therapy, we saw a lot of patients, they had hemorrhagic strokes, and a lot of these, they had increased mortality and really bad outcomes. So the question that came along is, can we identify a group of patients with submassive PE that would actually benefit from low dose or catheter-directed therapy or ultrasound-assisted thrombolytics or even mechanical thrombectomy in the submassive group? So the massive group, we know for the guidelines says lytic therapy. We still can use pharmacomechanical therapy, but lytics. The subgroup, it's still a gray zone. And that's the group, subgroup that I'm referring to here. So whenever there's shock, arrest, death, it's massive by definition. Are we able to risk stratify these patients by RV dysfunction before they get to the shock state? So a lot of predictive models have came along. The most recent one and more commonly used now is the PESI score. The PESI score has, and if you go to your MedCalc, or if you go online and you look up PESI score, it's easier to use the simplified one actually, and then you can plug in if the patient is more than 80, history of cancer, history of cardiopulmonary disease, the heart rate more than 110, blood pressure less than 100, and if the O2 sat is less than 90, and that by definition helps you risk stratify even the submassive group. Nationwide, there's a big move towards the PERT team, and this was started at the Mass General Hospital, Kenny Rosenfield. And these teams typically included cardiology, cardiac surgery, radiology, the ER, the intensivist, and even the anesthesiologist. And an early identification of severe PE patients, a PERT page is activated and put all these patients on the line. And then the decision is made as a group how to proceed with the management. However, we learned along the way that too many cooks in the kitchen really made this team is inefficient. The whole team is on the line in the middle of the night, and then we end up deciding on anticoagulation only. Our team is actually at Orange Park at Memorial is pretty unique that it only includes the interventional cardiologist, the ER, and sometimes the intensivist, and that helps us go with more practical decisions. So what are the endovascular treatments of patients with acute PE, and when do we use them? So if there's contraindication for systemic thrombolysis after failure or of initial or ongoing thrombolytic therapy, so you give lytics and the patient keeps decompensating. If you're looking for rapid central clot debulking, there's you want to decrease heart strain or increase the pulmonary perfusion. If you want to expose more surface area of the thrombus to the effect of the local agents, and if you want to minimize bleeding associated with systemic lysis. Surgical embolectomy, this is an example of surgical embolectomy. This is a patient with massive PE, went to the OR, the good old age, open the chest, get the thrombus out. But we know that these patients are sick to start with, and these surgeries are associated with high mortality and morbidity. For our catheter-based interventions, suction thrombectomy and aspiration thrombectomy is something we use, and we use it at Orange Park. And we can typically use it when there is absolute contraindication to systemic lytics, or even in the absence of absolute contraindication to systemic lytics. This is, I don't want you to be overwhelmed with all these tools and toys that that are available. This is a device that's used for thrombus fragmentation, where we go to the main PA. This is shooting in the right pulmonary artery. This is the contrast. This is a thrombus here, the filling defect. This device is being used to fragment the thrombus and allow more surface area for the lytics to work. The good old aspiration thrombectomy, but this is the old device. We try to aspirate the thrombus Two dedicated devices came on the market recently for aspiration. The penumbra device, which was originally developed for stroke interventions, and Dr. Al-Sagir is very familiar with this, used it for his stroke aspiration and thrombectomy patients. Now the company had came up to 12 French bigger catheters for dedicated pulmonary thrombectomies. Inari FlowTriever is a device that we use for these PE patients. It's up to 24 French. It's a big hose that you go to the pulmonary artery, try to suction out the clots, and this is some of the clots that we can get out on good days. And this is the example of the Inari FlowTriever device. It's a quick caption. We go up with a catheter up to the pulmonary PA, the pulmonary artery. We cross. We have the option to deploy these discs. And there's literally just getting close to the clots and getting the clots out without the use of any lytic therapy. I really wish it looks like this in reality. It's a little more labor intensive and a little more difficult, but we've always been lucky to get majority of these clots out. So I'll go over a quick case, and I will be presenting these cases as the presentation goes along. This is a 54-year-old patient who is MRDD, autistic. He's got a history of subdural hematoma. Post-craniotomy, he was at a SNF. He developed acute dyspnea. He was found to have DVT-PE. And by definition here, his heart rate is 84, his blood pressure is 92, so it's more than 90. He's starting 100% on 2 liters nasal cannula. So this is submassive by definition. On exam, he's pre-dyspneic. Troponins are positive, BNP elevated. So this is submassive PE, the positive biomarkers. The simplified PESI score is 8.9, and so it's high risk. And there was concerns for ongoing subdural hematomas, so patient was taken to the cath lab. So this is echocardiogram, and we're looking here at the 4-chamber view. Just quick orientation. This is the left ventricle. This is the right ventricle that is very enlarged. Typically, the right ventricle should be less than 2/3 of the left ventricle. So the RV is enlarged, and even the septum is bowing towards the left ventricle, causing it to be underfilled and causing more hemodynamic compromise. So patient was taken to the cath lab. This is the PA angiogram, the right PA, the left PA, and you see there's not much contrast going to his lungs, and there's the filling defect here at the center of the right main PA and even the left pulmonary artery. So multiple runs with FlowTriever, and this is the angiogram after. So this is pre, and this is post. There is more perfusion to the upper lobes. And this is some of the clots we get out of pulmonary artery. So different other devices that you may hear about, but we don't have to talk about them in details. The radiative therapy, angiojet, you may hear us talking about them more in the peripheral arterial disease or even peripheral venous disease, which is a device that breaks the clots and aspirate. Has a lot of possible side effects, including renal failure, hemoglobinuria, AV blocks while doing rotational thrombectomy is another device that we can use, or the good old angioplasty in dire conditions where we're trying to improve the blood flow and reduce the obstructive shock. So catheter-directed therapy or ultrasound-enhanced catheter-directed thrombolysis, you hear us talking about ECOS most of the times. It's another pharmacomechanical approach to acute PE. So we're using drugs here. It utilizes sophisticated catheter systems, and it uses high-frequency, low-power ultrasounds. And the goal is actually to break the fibrin and expose the thrombus more and increase the surface area, increase the thrombus more to our lytic agents. So these are different waveforms that are transmitted by the device, and this is the fibrin without ultrasound, and these are the fibrin complexes with ultrasound. You see there's increase, it breaks them down and increases surface area to the lytic agents. And this is based on a few trials that were done back in the days from 2010 to 2013, Ultima trial and Seattle 2 trial, and this is the protocol that we typically use for our TPA infusions in our ICUs. So this, and it's a small number. These are typically single-armed studies, ECOS with TPA for 24 hours or 12 hours if you're doing 2 catheters. Total TPA dose is 24 milligrams. And remember, systemic TPA is 100 milligrams, so you're using less than a quarter of this and the amount of TPA, which is typically reflected in less hemorrhagic complications. This is the first ECOS patients that was back in the days done in the Cleveland Clinic systems. You see the right catheter, the right ECOS catheter going to right PA and the left PA. And this is the echocardiogram pre, the right ventricle is dilated, echocardiogram post, the right ventricle size is reduced and the function is actually improved. So there's a paradigm shift nowadays in thrombosis and clot management. Similar to myocardial infarction, where systemic lytics were the first line of therapy for STEMIs. Now we're using balloon angioplasty, bare metal stent, and drug-eluting stents. And urologists are like cardiologists, about 10 years behind. But also, they started with lytic therapy. A few studies came along, and now thrombectomy is sometimes the first line of therapy. Also, for venous thromboembolic disease, we also started with systemic thrombolytic therapy. Also, few studies came along, few devices are available. And now we're going more for debulking and getting a lot of the clots out. So from acute clots to chronic clots, from red to white, all of these, they were able to get them out in the cath lab. And none of the studies or data is a randomized data. All of these are single arm, but they're pretty promising. So FLAIR study, this is the study done by the Inari device. This is the big device that we actually have it available at Orange Park. Looked at, it's a single arm, multi-center, 106 patients, 18 sites. These patients came with submassive PE and they were taken to the cath lab. They were eventually at 25% reduction in RV to LV ratio and with 0 TPA used, and the median ICU stay was 1 day. 42% of these patients, they did not even go to the ICU. Remember, any patient that comes, we do ECOS, we send patients to the ICU for fibrinogen and for monitoring and closer monitoring. So to put this in context, the FLAIR trial that used the flow retriever or mechanical thrombectomy used 0 TPA, 25% reduction in RV to LV ratio at 48 hours. Seattle 2 used ECOS, used up to 24 milligrams of TPA. There's also good amount of reduction of the RV to LV ratio, but there were more increased bleeding complications. In terms of safety profile, FLAIR had only one major bleed. It was actually a groin access complication, no intracranial bleed, compared to Python trial or Seattle 2. In Python, there was 2% risk of intracranial bleed. And remember, the mortality is pretty high when you get a hemorrhagic complication intracranially. So the FLASH registry, this is also performed by the Inari crew, enrolled 230 patients. We have some interim data. 93% of these patients, they were intermediate risk. 7% of these patients were high risk. RV to LV ratio was 1.6, so that's pretty sizable PE. Interestingly, on the spot, all of these patients did actually not go to the ICU. On the spot, interestingly, we noted a decreased on the average drop in heart rate was 22 beats per minute. So patient come in distress, heart rate 110, 120. Right after thrombectomy, the heart rate goes down 22 per minute on average. And there was 7 millimeter drop in the mean PA pressures. Mortality was 0% at 48 hours. At 30 days, there was 1 death reportedly not related to the PE. So a quick example, this is a case I think was done in Cleveland. You may have heard about her before. This is a 39-year-old lady with a history of large orbital rim meningioma. There's an Amish community in Ohio. This was an Amish lady. Got a history of DVT, and she was on 3 months on Xarelto, and she's taking now some herbal medications as a blood thinner. Had her intracranial surgery. 5 days later, she had sudden onset tachycardia, oxygen requirements increased, heart rate 120, blood pressure 70. So this is by definition a massive PE. She was on 2 pressors. and she had a CT angiogram concerning for bilateral PEs. The CT angiogram, she has the saddle PE. This is a thrombus, the filling defect that we keep referring to. Interestingly, the right ventricle is larger than the left ventricle. And clinically, this is a massive PE by definition. It's the echocardiogram. The RV is dilated. The left ventricle is small and compressed. So patient was taken emergent to cath lab. On arrival, she deteriorates even more, goes into PEA, resuscitated, VT, shocked. We eventually obtained ROS. This was a very big lady in the cath lab. Eventually, we decided to proceed with emergent VA ECMO, and then subsequently after that to go with thrombectomy. So this is the first shot of the PA angiogram. Again, this is a filling defect here, and there's not much flow to the right, middle, and lower lobes. After a couple runs, there's improved flow to the lungs. On the left side, same thing. There's a filling defect here, multiple runs, and there's improved blood flow. And this is some of the clots that we got out. Remember, when dealing with obstructive shock, the goal is not to clean up all the thrombus that is available. It's just to reduce the obstruction and unload the right ventricle and improve the hemodynamics. This patient was on ECMO regardless. So a few days later, a week later actually, you see the LV is hyperdynamic here. The right ventricle has been decompressed and went back to normal. ECMO decannulated, and the patient was discharged home. So what about DVT? I know we're probably running a little bit out of time. So what about DVT? Deep vein thrombosis is also a high acuity condition. It's the #1 cause of PE, is actually embolization of DVT. And I mentioned earlier, 50% of these patients, they develop post-thrombotic syndrome, which is pretty debilitating. And when we see them in clinic and they already develop the syndrome, we actually can't do much because the large amount of thrombus in these femoral veins or below the knee already damaged the valves that are there. And these patients, they have to live off with edema and pain and even sometimes ulcers. So up to 90% of these patients, they're really unable to work at 10 years after diagnosis. So what do we do for these patients at Orange Park or even Memorial? I know Dr. Ali and Dr. Lamba do these procedures at Memorial Hospital. This is a young lady that some of us may be familiar with. She had a history of axillary bifem bypass for an occluded aorta. She was not evaluated by us for her vascular disease. So she had an ax bifem. Her left femoral groin has dehisced, infected, subsequently developed a DVT and came with a large, massive left lower extremity. We were consulted late to deal with this, with the DVT, not her arterial disease. So we took her to the cath lab. The first venogram, you see there's no flow in the femoral vein. After a few runs of the Inari, this is the basket that we use to get all the clots out. There's improved flow in the femoral veins and even the iliac veins. And a day later, this is her leg completely shrunk. So another case, 38-year-old guy with right lower extremity DVT. I think also some of us remember this young man, large, massively swollen, edematous right lower extremity. We also took him to the lab. We did a few runs of thrombectomy, and the patient was discharged home the day after. What about right upper extremity DVTs? This is the 24-year-old man, also came with right upper extremity DVT. We used the Penumbra device here, which is a smaller device, and we debulked a lot of the thrombus, and his edema markedly improved. And we saw him in clinic actually last week. He's being set up for first rib resection. This is another young lady, right upper extremity DVT, thrombus, no flow in the subclavian veins. So we're shooting dye here and from the brachial vein side. And it goes to the axillary subclavian, and there is full occlusion here. You see some collaterals, but they're too small to drain the arm. After a few runs, and we got some of the clots out, flow has improved, and this lady has also a thoracic outlet syndrome, and she's being set up for rib resection. This is a 54-year-old guy, multiple DVTs, came also with right upper extremity, a 2-week-old case. The filling defect here is thrombus. This is the brachial vein up to the axillary, full of thrombus, no flow. Few runs of the Inari device now. We went from the groin, and we got a lot of clots out. He even felt too good. He just disappeared from the hospital 3 hours later, and we couldn't find him. So same for PE management, for DVT management. From lytic therapy versus mechanical thrombectomy, classically, we used to put lysis catheter in these patients, wash them in the ICU, bring them back for a relook, do some angioplasty or venoplasty or even thrombectomy a few days later. With the new devices and equipments that we have now in our hands, we do thrombectomy, we stent them if we need to, and we don't send them we don't send them even to the ICU, where total length of stay is 2 in the cloud registry. I think that's it. But I have some couple slides on DOAC dosing because I keep getting asked these every now and then. So we have few DOACs that are available, as we know, and a lot of them. We can do another lecture for DOACs dedicated, but a lot of these medications they have indications and things to watch for, including renal function or sometimes liver function. So dabigatran Pradaxa is an oral direct thrombin inhibitor. It has low plasma protein binding, so it's dialyzable in case a patient comes with a massive bleed, God forbid. You can do dialysis and you clear them up. The dosing is for VTE treatment is 150 BID for 5 to 10 days following parenteral therapy. So you have to start these patients on Lovinox. Be cautious with creatinine clearance less than 30. For AFib, it's a different dosing. It's 150 BID, and then you reduce if the creatinine clearance is 15 to 30. Rivaroxaban, Xarelto, the dosing for VTE is 15 milligrams BID for 21 days, then 20 milligram daily. For prophylaxis, is once a day, and the Xarelto is given with food for better absorption. Eliquis, it's something we use pretty frequently. The dose is actually 10 milligrams BID for 7 days, then 5 milligrams twice a day. And we reduce the dose if you have 2 out of 3 factors. If the age is more than 80, creatinine more than 1.5, or weight less than 60. 2 out of 3, we reduce the dose to 2.5 BID, but this is for non-valvular AFib. For DVT, we keep it at 5 BID. I think that's it. Thank you. I think we're on time.
Awesome. Thanks, Dr. Younes. If anyone has any questions, you can just take yourself off mute and ask away.
I may have been super clear.
Come on, guys.
Okay, so I'm going to ask a silly question. This is Brenda.
Hi, Brenda.
So have you found where one versus the other could cause more of a clotting cascade to worsen? Or am I just barking up a wrong tree?
I'm sorry, have I found what? Which causes?
Have you found using the ECOS versus the Inari or any other lytic therapy which could trigger a worsening clotting cascade?
So that's a very good question. So if we want to talk about PE specifically, I disagree with how the companies promote their equipment as this is the one and only device that you should use for PE. I think we still have to personalized care. So patients with subsegmental PEs, pretty small, not a heavy thrombus burden, still with RV strain, I think ECOS is the way to go still. Patients with the central clots, still with RV strain, I think Inari works best. That's on one hand. I think for DVTs, when we do the thrombectomy and we try to get all the clots out, the device actually is a little bit traumatic to the vein. and it may trigger, it denudes the endothelium, and it may trigger more clotting, and that can even worsen the thrombosis. So these patients, they have to be, as soon as we get the thrombus out, the device out, the echos out, we have to start them immediately on anticoagulation.
Thank you.
Thank you.
Hey, this is Erin. I have a question.
Yeah.
So for people with PTS, if they're like, a couple weeks out from a DVT, so there's no benefit if they're still having, pain and swelling in the leg to go and do a procedure if they initially did
This is a
anticoagulated?
and I think you touched at the right topic. So thrombectomy in the acute setting, when the thrombus burden is heavy and the thrombus is still mushy, is more successful, as opposed to when it's already has fibrosed and went to the chronic phase. So early intervention and getting us involved early on usually serves the patient best. Unfortunately, we still get referrals to our clinics. Patient had, a DVT 4 weeks ago, and he's having swelling now. There's no clear data that doing thrombectomy at that time will 1000% help the patient. I still tell them that, but we know that central debulking, if there is a lot of thrombus in the femoral vein, common femoral vein and iliac, we know for a fact that if you get the thrombus out, you will improve the drainage of the leg and improve the blood flow. So patients still get benefit. We still do the thrombectomy. It's a little more challenging as opposed to fresh thrombus. We still get a lot of the clots out. And at the same time, if we find that we did not achieve a lot of the thrombus out, we do balloon angioplasty, and that even helps drain the leg more. So I think it's still worth it for these patients because it's a pretty debilitating condition to live with PTS. All they can do is compression stocking, elevate the leg, and hope for the best, basically.
Is there a time cutoff where if it's been like 2 months, you're like, there's probably no hope at this point, or?
No, I would still take them to the lab.
Okay.
If there's a lot of thrombus in the femoral vein, the common femoral vein, I would still take them to the lab. At least they would benefit from maybe angiojet or balloon venoplasty, and that would help drain the leg a little bit.
Okay.
And also, these patients, we tend to miss, we know these patients that had DVTs, but we tend to miss the fact that why did they have the DVTs? A lot of these patients, they have iliac compressions that is undiagnosed, and now thrombosis has been triggered by an event, surgery, travel, or trauma. These young ladies that come with May-Thurner syndrome that remain undiagnosed for years, treated with anticoagulation, multiple rounds of DVTs without anyone investigating. So I think there is definitely a value for taking them to the lab, debulking, doing some imaging of the iliac veins. We use IVUS, we use intravascular imaging, and that would help you, and stent the iliacs if you really need to keep the vessels open.
Anyone else, guys?
Since I missed most of the presentation, can we get a copy of it in an email?
Yeah, sure, absolutely.
Okay, thank you.
Who was that?
Sharita.
Sharita.
Awesome, guys. Well, I will make sure to give CEU credit to the nurse practitioners. I'm sorry we can't do this. We can't do CMEs for the PAs. And then we'll go ahead and plan the next talk. The next talk will be Dr. Fadi. He'll be speaking on new echo specs. And we'll keep these consistent every 6 weeks or so. So if you guys have a topic that you'd like to hear about, please just shoot it over to me in a text or email, and we'll be happy to make it happen. But thank you, everyone, for joining us. Thank you, Dr. YOUNES, so much.
Thank you.
And we'll see everyone soon. Have a safe evening, guys.
Thank you, Dr.
Thank you.
Thank you, Dr.
Thank you.
YOUNES.
Thank you.
Thank you.